back. We were just getting settled with Dr. Pope there during the break. I think some of you might have seen that. Dr. Pope, can you hear me still? I just, I unshared your screen for a moment, but I want to make sure that you can still hear me.
Yes, I can indeed.
Perfect. Wonderful. Welcome. Thank you for being with us. You know, you're such a great supporter and ally to us here at the SSO and SC. So thank you. It means so much that you're with us today. Dr. Pope is a professor of medicine in the Division of Rheumatology at the University of Western Ontario, Shoolage School of Medicine in London, Ontario, Canada. She is the division head of rheumatology at St. Joseph's Healthcare Centre in London. Her research includes studies in scleroderma, SLE, and RA, including outcome measurements, clinical trials, and disease manifestations. She's published over 450 peer-reviewed articles, 15 chapters, 500 abstracts, and several Cochrane meta-analysis reviews. Mentoring of research students and trainees numbers more than 125. She has received the Distinguished Investigator Award from the Canadian Rheumatology Association, Rheumatologist of the Year from the Ontario Rheumatologist Association, Department of Medicine Research Achievement Award, and the Dean's Award of Excellence in Research. So that's a lot to be proud of. We are certainly very lucky to have you with us. Are you able to? Oh, good. Okay, great. So you're, welcome. Thank you for being with us. I'll let you take over screen sharing now, Dr.
Great,
Pope.
excellent.
Thank you.
And thank you for those kind words. And I'm just figuring out here, I think I hit a new share, and we'll just put my thing up, which we'll find. Good.
I can see it. That's great.
Yeah, we will get it. We're getting there. Okay, let me just share again. There it is. Okay. And first of all, I feel very privileged to be part of this. In general, I never miss an opportunity to talk with the SSO members and other people that aren't yet members to really know more about scleroderma, because it is rare, and I think a person living with it or their family can be their best advocates. The other thing is, in these troubled times, I'm glad we went ahead with this. The World Congress got canceled, which would have been exciting information to bring back to here. And then it was postponed and eventually occurred, but the patient component didn't. And the US one, the patient component, the whole meeting got canceled, other than a young investigator meeting that was important. So I'm glad that we've gone forward to do this. So for true disclosures, I am not a gastroenterologist. I can't be the one to dilate the swallowing tube and things like that, but I can certainly, I've learned a lot from my patients and from gastroenterologists, from the literature and from clinical experience, and I think there will be some tips that can help people for sure to understand this. These are my various disclosures for consulting and other things like doing trials, things like that. So I really want to discuss how scleroderma can affect your gut or your GI tract, gastrointestinal tract, and to look at different treatments for different symptoms in different areas of the bowel that can be involved. And I think, as I say, a lot of people suffering from scleroderma will have a GI complaint, so or a symptom, and so hopefully you'll shed some light on this by this. So we published a long time ago the various ways that scleroderma affects people living with it, and all of you who either have a loved one living with it or a friend or are living with it yourself know that it's way beyond skin. It affects your physical health, your personal life, your mental health, and your social life, all for each person potentially. And you can see all these little circles around it of the things that can be affecting. And so when I dwell on GI, there's so many other symptoms and things that can be going on, but GI is so common. Then when we look here, there's obviously the different organ systems, and I will be going through it in more detail, but from really top to bottom, it can be affecting your bowels. So acid reflux and problems swallowing, being discoordinated is very common. Constipation, diarrhea, sometimes incontinence. having severe diarrhea and not absorbing your nutrition, and very rarely even causing a perforation of the bowels, but even the anal sphincter can be involved. So we will go into this. So good for Google Images. I found something because I'm only going to briefly talk on your mouth and your salivary glands, the glands that start to break down your food are in your mouth, like your parotid glands and other minor glands. We're going to spend a long time talking about the swallowing tube, the esophagus. We won't talk much about the liver or the gallbladder or really the pancreas, but we're going to talk about the stomach, the small and the large intestine, the rectum, and the anal sphincter tone as well. So it's going to be a whole bunch of areas because sometimes the treatment is different. So many people with scleroderma, about 15% will have significant dry mouth. So it's harder to digest your food if you don't have the starting of your digestive enzymes in your mouth. And that dry mouth is sometimes part of Sjogren syndrome, which is an autoimmune condition that can occur and as an overlap in scleroderma with autoimmune dry eyes, dry mouth. But even if you don't have that overlap, you can have dry mouth because your glands get infiltrated with collagen, or the fibrosis, the scarring, just like on your skin, and that can make less secretions, less ability, of course, to open your mouth, to chew and your food, to digest your food, and to swallow it with what's going on with scleroderma. And because of acid reflux, you might have bad breath, you might have very damaged teeth. The saliva being poor quality, not as good and not as like normal, less of it can worsen the swallowing problems and lead to various other problems. So for things like dry mouth, we sometimes will say all sorts of products that I'll get into, but also we want to avoid acid reflux, which can worsen it. So we sometimes want your mouth more lubricated. So patients have told me that they use edible coconut oil sometimes, and all that's doing is coating it to make it feel less dry. Biotin products like artificial saliva, Biotin mouthwash, which was developed for people with radiation injury in their mouth. So it's gentle but can clean it better. Using agents that help us digest food, that help us propel food down from our mouth to the swallowing tract down into the stomach. So there's various treatments. None of them are totally great. There's sometimes pilocarpine or even glaucoma type eye drops, timolol or pilocarpine eye drops that can go under your tongue to try to make more secretions or saliva, but obviously you're not using the eye drops because you have glaucoma, you're using them to help make secretions. So there's a lot of different things. Everything I just said is off label, but there's lots of things we learn from the GI doctors to help our patients. The other thing I learned from a dentist a couple years ago at the Scleroderma, the Canadian meeting, the SSC meeting, was soda water, because soda water helps break down some of the bacteria in your mouth. And I had never thought of that. And that was a nice tip for my patients. If you have bad teeth, which is sort of not part of your GI tract, but part of the whole, area of eating, fluoride trays, because the acid reflux can do a real number on your enamel. So you can be really dry, like this person's picture of the tongue here, really dry in your mouth and not look like a dry tongue here. So what we see as physicians or healthcare providers and how you feel don't have to correlate. So really there's lots of things that can help. We also say avoid sugar because we don't want poor dental hygiene if you can. Sugar-free gum can help you make secretions more if you need to. Go to the dental and the dental hygienist more, even though it's COVID, still go. And don't drink bottled water. I learned that tip as well. So soda water can help break down some of the undigested food that's in your mouth because your secretions aren't right in your mouth. And I'm sure we'll have great questions and we'll have time for that. So these are some of the tips that I've mostly talked about, and for dry eyes, which isn't part of your GI tract. But if you have bad dry mouth, you sometimes have bad dry eyes. That would be artificial tears and some of these other things as well. Now we'll get more into the swallowing tube called your esophagus. So basically, almost everyone with scleroderma, about 80% of our people living with it, my patients, about 80% will have discoordinated peristalsis. So you should have right nicely coordinated right down your swallowing tube. And scleroderma can be like this. It's not tight, good waves, and it's not coordinated. It's all over the map, but not strong. And although that can occur in 80%, significant food sticking issues is probably 15 to 25%. It can worsen with disease duration, but not necessarily. And then, as I say, we're going to talk about these other areas, particularly small bowel, large bowel, colon, and rectum and anus. So the gut involvement, about 90% of people living with scleroderma has some gut involvement somewhere. So it's very, very common. And it's a common complaint of pain, suffering, and poor quality of life. And the upper picture here is the swallowing tube of a person with scleroderma. And you can see it's really wide or big at the bottom. That's not their stomach on that x-ray. That's their swallowing tube is quite dilated. And what happens is the discoordinated swallowing, the swallowing tube has scarring or fibrosis in it. The muscles that contract have scarring or fibrosis, and or the nerves that tell your gut to have normal peristalsis that's coordinated, that those contractions. There can also be fibrosis around where the nerves are. And so the bottom of the swallowing tube can really dilate. And so the sphincter at the bottom of the swallowing tube, like the lower picture, can be inappropriately opened. And in the lower picture, you see this red, which is ulcers or erosion. So that's esophagitis in the dilated swallowing tube. So the swallowing tube should be the same length all the way down. And you can see the length goes quite wide. So really any site can be affected. Severe gut involvement somewhere along the way is 8%. So that's 8 out of 100 of the patients, but 9 out of 10 of our people living with scleroderma will have some degree of problem going on. And it certainly can decrease quality of life, increase morbidity, and you can have sometimes, rarely in that 8%, some will have malnutrition, which is not compatible with good, healthy life. So we'll talk about the esophagus or swallowing tube in the stomach. So this is data from our Canadian Scleroderma Research Group. And we were looking at, you know, how frequent is GI tract involvement. So it can worsen with disease duration, but you can have it early as well. It's quite common. So having significant GI involvement, complaints of acid reflux, as a for instance, acid reflux is called the GERD, G-E-R-D, or gastroesophageal reflux. Look at 75% of the patients with the diffuse subset, that's more skin involvement, lots of GI involvement in them, 3 out of 4 people, and 70% or 7 out of 10 and the limited patients. And needing a dilatation of your swallowing tube by the GI doctor or sometimes a general surgeon, look at 1 in 6. So about 15% of our patients are needing that. So it is very common. So acid reflux is common in the general population, even more common in scleroderma, and often far more severe. And needing esophageal dilatation is about 1 in 6 of our patients. And this is showing you on the bottom the normal contractions of the swallowing tube. So they're in a series. It goes one, the next, the next, the next, and then it relaxes and starts over. And these are big waves in a coordinated fashion. The one above is supposed to be the same thing with someone with scleroderma swallowing. And I think you can kind of say it looks like a flat line. We just don't have that good contractility. And in fact, in this person with scleroderma, there is no contractility. It's kind of like swallowing down a lead pipe. So not always is the esophageal problem symptomatic, but it certainly can be. And having this problem with the valve at the bottom of the swallowing tube also open allows for free acid reflux to come up. So what's our treatment? Lots of things we can do to help. The proton pump inhibitors, that's your Losec or omeprazole, Nexium, which is esomeprazole, lansoprazole, pantoprazole, all those things that sound with opazole, rubeprazole. They're the kinds of drugs we use, and they have other names, Pantaloc, Prevacid. They have names that are trade name or generic. And we not only treat, we often give double dose, triple dose, occasionally quadruple dose. So a regular person without scleroderma with acid reflux might need a proton pump inhibitor. Usually single dose is fine. For our people living with these poor contractions, right, with scleroderma, it's often triple dose or double dose. We often add those H2 blockers, which are ranitidine that was off the market for a bit, famotidine, Pepcid, cimetidine, Zantac. Those drugs can be additive to help. We sometimes will give drugs that increase motility to try to propel the food down, to try to make some of the waves of the esophagus be better. And that's the prokinetic drugs. And that would be your domperidone or Motilium, your Maxaran or metoclopramide. It would also be sometimes drugs, again, often off-label, Risatran or percoloprolamide. We say don't eat after supper. If you get worse acid reflux with all the good things in life like chocolate, peppermint, alcohol, then avoid those things. If you don't get worse acid reflux, you can still do it. Raise the head of your bed. Avoid the triggers, and especially just at nighttime, if you know you're going to get acid reflux, that can be bad on your lungs. So we really want to avoid that. And it's terrible to wake up with acid in or food in your mouth. So just don't eat after supper time. Don't pig out right at bedtime, in other words, and keep that bed elevated. If you raise only your pillows, you're going to fall off your pillows. So we usually say raise the head of your bed with a couple 2x4s on the head of the bed, where the bottom of the head of the bed is, to raise it up. So also, if you get ongoing acid in your swallowing tube, your swallowing tube should have a low and like a normal pH. It shouldn't be acidic. It should be more a base. If you're always getting high acid coming up, you can start getting the bottom of your swallowing tube changing to stomach kind of lining, and that's not supposed to be there. And stomach lining in your swallowing tube and your esophagus can lead to what's called Barrett's esophagitis, which can rarely lead to cancer. So if you have that, then you're scoped every 2 to 5 years to follow that. And Barrett's esophagitis is maybe only 3% of my patients with scleroderma, even though many more have severe reflux. Okay, also, so I'm just kind of going down here. So in your stomach, you can have iron deficiency anemia, low blood, low iron, because of this stomach here of watermelon stomach. And it kind of looks like a watermelon. So all that red stuff shouldn't be there. The pink should be, the red is abnormal. It's dilated blood vessels, just like you can get the little dilated blood vessels of those round dots on your face or your hands or elsewhere, the telangiectasia. These are bigger versions of that. They're funny blood vessels that have gone wider, and they're friable, meaning you can put food or acid in your stomach and they might break down and bleed. And they keep bleeding, so you don't see your bleeding. It's occult bleeding. It's just a little bit here and there bleeding. A little bit adds up to a lot. So it's like a woman having heavy periods. You can get iron deficiency anemia. Having bleeding ongoing in your stomach can give iron deficiency anemia. And that's treated by zapping all these areas, scarring them down with laser. And sometimes that works really well, but often you have to get repeat laser over time. So if someone gets really anemic again, I say, we got to send you back to GI because they probably have to zap your stomach some more. So it is treatable and we can't forget about it. And again, that's maybe 3% of my population, maybe at most 5%. Far more commonly, the stomach, instead of being a nice muscle, an organ that contracts and shoots food out in a timely fashion, often we can have delayed gastric emptying. So your stomach, your food can sit there like a ball, not digesting, like a lead pipe instead of a nice muscle. And if you have food in your stomach, you can feel full early. It can worsen your acid reflux because it's putting pressure on that open valve of your lower esophageal sphincter. And it is very uncomfortable. You eat and you're full really early and you go, that's crazy. Or people say, oh, you weren't supposed to eat before the scope. You found a whole bunch of food, and you go, that's food from yesterday. I haven't eaten like you told me. So the undigested food just kind of sitting there like for a long time, which is not a nice feeling. And we do sometimes use motility agents, which is important to, again, propel through the stomach. And basically, the pro-motility agents would be the ones I mentioned, that Maxaran, metoclopramide, domperidone, motilium, and then off-label, sometimes drugs we use for irritable bowel that can propel food through the stomach, like Risatram, which is percoloprolamide, or other ones. Now, I'm seeing some good questions come in, and the first one I'm going to answer later. It's how do they get a family doctor, and how do they see a rheumatologist? So I'll answer that in a while. But there is a question of somebody saying that their young son who's 17 has scleroderma, not on the skin, but on the organs, and has the dilated esophagus. And basically, there are lots of treatments in the gastroparesis. You can try some of these things. And yes, you can use metoclopramide 3 times a day. And in fact, we can often go up on the dose that's tolerated to a maximum of 5 milligrams 4 times a day, rarely 10 milligrams 4 times a day. And that's the same with that domperidone. And sometimes we also rarely add erythromycin. It's on back order currently, a lot of the doses. Erythromycin you might have heard of as an antibiotic, but erythromycin in regular people gives diarrhea. In scleroderma patients often improves the contractility and treats the bacteria if they have small bowel overgrowth, which we'll talk about. So that's other things that could be used, and that's usually the GI doctor helping you, or else a doctor that has a lot of scleroderma patients if it's the rheumatologist. So lots of people will also have bloating, feeling full early. So that's called early satiety. You feel full early. And sometimes you feel like you're pregnant, lots of gas, and then you might get this rush of diarrhea intermittently. And so you can feel full early because your stomach is like a lead pipe instead of a muscle, and things aren't contracting right and the food's sitting there. But you can also have bloating, early satiety, or feeling full early, and intermittent diarrhea, because we try to neutralize acid in your stomach, which doesn't help you digest your food, but because the acid's coming back free flowing in your esophagus, your swallowing tube, and sometimes into your mouth. So if I'm neutralizing bacteria and your food are sitting like just sitting in your stomach, as your food goes into your small bowel, there's a lot of bacteria growing, because bacteria can be killed off with acid, and we're trying to suppress acid so we don't get worse erosive esophagitis, worse acid reflux. So the bacteria can grow, and bacteria, as they grow, they make gas. It makes you feel pregnant, and then you can just get a flow of diarrhea happening. And so that small bowel overgrowth is also called SIBO, small bowel intestinal overgrowth, or small intestinal bowel overgrowth. And we need drugs to knock down the bacterial count and to give better contractility. So you can see some of the drugs overlap and some don't. So if you have small bowel overgrowth, or SIBO, we want to rotate antibiotics. We want to use something that is tolerated to help you. And sometimes we have to give antibiotics, a 5 or a 7 day course, normal dose or low dose, every 3 months. So, in some people it's once a month, and in some people it's even rotating all the time, because they're losing their nutrition, they're losing weight because it's so severe. And we experiment on what works. I mentioned erythromycin, but amoxicillin or amoxil can work, clarithromycin, Flagyl, which is metronidazole, ciproflox, one that's not absorbed anywhere but in your bowel, rifamycin, but it's not covered on some of the drug plans, so I don't always do that. So there's a lot of stuff. We're doing a trial with the Canadian Scleroderma Research Group on probiotics to see if they will help. And not probiotics, just the pills, but probiotics that are high bacterial counts are often in the fridge. So it's a bit different than yogurt, and to see if that will help. Erythromycin is safe if there's a penicillin allergy. So great question. It's a different class of drugs, whereas penicillin and amoxicillin sometimes cross-react about 10% of the time. Erythromycin's fine. What causes this small bowel overgrowth? It's because we're neutralizing acid in your stomach on our drugs, the proton pump inhibitors, the acid reflux drugs, but it's also caused because you're having basically the muscle of your stomach isn't working, so the food's just sitting there. So we worsen it by our treatment of acid reflux, and your disease has worsened it because you don't contract your food. Yep. Okay, then here is looking at a person with problems with the small bowel overgrowth. They're all bloated, could be, but this is also a person, they're not just bloated up here in their epigastrium area, they're bloated down here. So this is the large bowel. And if you have large bowel involvement, which some of our patients do, you might have diarrhea, you might have constipation, you might have gas and bloating, you might have a poor appetite and weight loss, and it might be bad enough that you have a bowel obstruction where you need a tube to going down your stomach, a nasogastric tube, to put your bowel at rest. We treat this, even though you have diarrhea, we kind of treat diarrhea and constipation a little bit differently, but some principles the same. So using drugs that help the contractions be more normal, those drugs I mentioned, like that domperidone or Risatran, those drugs. If there's severe diarrhea, we sometimes have to give drugs like Imodium or loperamide, or rarely the opiates. That's the codeine kind of drugs to stop the diarrhea. Rarely do we use octreotide, which is an injection to try to get better large bowel contractions. By the time I use octreotide, it's expensive, it burns, people don't like it. It often doesn't work because I use it in the worst case scenario patients. We try to change around the nutrition. Probiotics might help, and we sometimes have to even give parenteral nutrition short-term or long-term. Large bowel involvement is less than small bowel involvement. Yep. So we have asked Scleroderma experts. So again, they're not GI, they're rheumatologists by far and large. How do we treat these things? So there was a lot of agreement. So if you have the upper bowel, we are going to use the high dose proton pump inhibitors for the acid reflux, promotility agents, and then dilatations if they're needed. Rarely surgery is needed for the acid reflux because sometimes it doesn't help the scleroderma bowel to do severe acid reflux patients having a surgery. For small bowel overgrowth, antibiotics, no one agreed on the antibiotics, so here's a list here, and then otherwise promotility agents. Pseudo obstruction, use the promotilities. If you have bad nutrition, we try to give better nutrition, even by a feeding tube or parenterally, but not usually needed. For the watermelon stomach, giving the laser repeatedly as needed to stop the iron deficiency anemia. But the watermelon stomach doesn't hurt. You don't necessarily know you have it. We detect it when people have low blood, like anemia. Constipation, laxatives, stool softeners, things like that. Incontinence is a big deal that I'll talk a little bit about. Incontinence is because your rectum might be dilated instead of a nice tight muscle at the bottom of the rectum, but the rectum itself might be dilated just like your lower esophagus is, your lower swallowing tube. And your anal sphincter can also have scarring in it because it's fibrotic, and that can cause problems with incontinence. So Kegel's exercises can help, sometimes biofeedback, sacral pacemakers. We would rarely send someone for that. That's done in Toronto. It's not done, I don't think, in Hamilton or London. And that would again be severe incontinence. We also want people to, look at their routine and try to toilet right away before they go out, things like that. But, rectal fecal incontinence is very horrible to have. It's a terrible problem. Okay, so these are some of the things that we will do. And then sometimes we use drugs for that for irritable bowel. And this isn't an irritable bowel. This is irritable because of scleroderma, but irritable bowel like Zelnorm and some other ones are not covered on the ODSP or the over 65 drug plan. So I don't use them very much. And there's Constella, but I often get the GI doctors to help me if I'm not sure what to do next. This is looking at the anal sphincter and the colon here. So you can see nice muscles in this normal. You can see lots of rings, like rings of a tree, right? Nice muscles, well demarcated. Here, look at the person with scleroderma. You can't tell where one layer goes into the next. And the muscles have been infiltrated with the collagen or the fibrosis. And again, this is a tough problem. So we think of things of how can we help the area? Is it more constipation? Is it more diarrhea? Is it some of each? What else can we do to help? So some people even go for physiotherapy for sacral nerve stimulation or to try to help this. I'll take any help I can get from any allied health professionals, any other experts and things like that. But Kegel's exercises can be helpful, which is push your butt muscles together, your cheeks of your bum together, tilt your pelvis, hold it so you're tightening your anal sphincter, your rectal area. Hold it a long time, relax again, and you can do that literally 1,000 times a day and no one knows what you're doing, so it's fine to do it. And that's the first thing that a surgeon will tell you. Most people won't need surgery for this, but it's not a nice area to be involved. So again, fecal incontinence, the pelvic floor exercises, trying to regulate your bowels because you don't want either the constipation or the diarrhea. Sometimes sacral nerve stimulation, which is sort of like a nerve stimulator that can be externally or internally implanted to help, hey, remember to contract. So it's giving like a pacemaker, remember to contract that, the nerves to contract the muscles at the bottom there. So again, we have the various things that we might do for the treatment for patients. So we also want to look at swallowing problems can be associated with worse lung function. So if someone is aspirating, having acid reflux, needing dilatation, waking up with vomit in their mouth or the acid, the stomach materials in their mouth, waking up with foam in their mouth that isn't from a cough, all those things can be pretty terrible, but can also make your lungs progress. And again, we did a study with our Canadian Scleroderma research group and found that progression of interstitial lung disease in our patients who had interstitial lung disease, looking over the next 3 years, the only predictors of progression over the next 3 years that we could find, not the extent of the lung disease, not like say bad ulcers, not the skin score, not the inflammation marker per se. The thing was having need for a dilatation, so the esophagus not working well, and severe acid reflux coming up into your mouth at night. Those were the most predictive of progressing lung disease over the next few years. So anyone with interstitial lung disease with scleroderma should raise the head of the bed. I think in general should be on the anti-acid, the proton pump inhibitors, and I think should also be looking at not eating after supper time, because you don't want to get reflux into your lungs to make the lung disease if you have it progressing. So I've tried to leave lots of time for questions, but I've covered really the dry mouth, the decreased oral opening, and poor dental hygiene. We've talked about the swallowing tube being very commonly involved. About 3/4 of our patients have acid reflux. The bottom of the swallowing tube being dilated with the sphincter being inappropriately open and poor coordinated contractions in the swallowing tube. We've talked a lot about acid reflux treatment. Then we've talked about the stomach with the poor emptying, the small bowel with the overgrowth and diarrhea and bloating and gas, the large bowel that can have things like that as well. And that some of our treatment is similar in the areas, and sometimes we have to figure out what's going on to get the best good treatment. And I couldn't be knowledgeable, certainly without the patients, but without our scleroderma societies within Canada and our funding organizations and our Canadian Scleroderma Research Group. So with that, I'd like to open it up for questions, and thank you for your attention.
Thank you, Dr. Pope. Let's get our question. I know that you had answered some of these as we were going along. I don't want to repeat. Okay, so did you get to this this Western student? You answered Kara's question.
Right, right. So the Western, because I thought that wasn't really in the flow,
No.
some of them were. So basically, student health. If someone has scleroderma and they're a student, like they've moved, right? Every campus has student health. And student health, they just say, you know, I have scleroderma. I'm going to be, you know, here learning for a while. Can you send me to a rheumatologist? And frankly, if the daughter is at Western, they should come to me because the student health won't know that. So say, please refer to Dr. Pope, and she knows the referral's coming, because our group will move a scleroderma no one patient referral to my office anyway. So it just saves one more, you know, going from one doctor to another. Yep.
That's great. Thank you. I think you addressed the recommended cycle for SIBO 5 days, one time a month.
Right. So it could be 5 days, once a month for the small bowel overgrowth. It could be just 5 or 7 days, very rarely. But I tell people when they know the crescendo is coming, they often feel it. They don't feel right. And they say their stomach is starting to act up, but it's very non-specific. They want to then, if they always have bad small bowel overgrowth, if this happens and gets worse, that's the time to take your antibiotics, not when you feel, oh my gosh, I can't eat. I have severe cramps. My pain's 8 out of 10 for the next 2 days. You want to try to preempt that if you can.
Okay. I have ILD and mucus plugs in my lungs, perhaps from aspiration. What are mucus plugs and how can I get rid of them?
Right. So you can have mucus plugs. So that's thick secretions and they can get stuck in the lungs. And people without scleroderma can certainly get that. And you might have thick secretions because of interstitial lung disease. You might have thick secretions because you do have less water, normal water content in some of your secretions, just like you can have the dry mouth from fibrosis or scarring or from the Sjogren syndrome. You can have thicker secretions in your lungs from the dryness there, like it's not proper mucus that's being made. It's thicker and not as easy to break up, but you could have it for a lot of other reasons. So with mucus plugging, they sometimes want to give Ventolin to open up airways more, and that's not, Ventolin doesn't treat, that's salbutamol, doesn't treat interstitial lung disease. And they sometimes give other puffers that will break down secretions, or even saline inhalations, depending on how bad it is, or chest physio. So there's lots of things it could be, and that's where you're going to talk with your respirologist and say, what else can help?
Thank you. Did we answer, do you see this top question here from Frank? Any research?
Right. So yeah, so Frank has a great question. So we haven't answered it yet. So any research looking at bacteriophages to target the bacterial overgrowth as opposed to using antibiotics. So that's where probiotics would be trying to put normal bacteria back into someone's, you know, for people with C. difficile, which isn't scleroderma, that's a different problem going on. They're trying to put bacteria in to get rid of the bad bacteria. So bacteriophages are being looked at, not particularly in scleroderma small bowel overgrowth, but in small bowel overgrowth for any reason, diabetes, gastroparesis, and other reasons as well. So we're not there yet to give you an answer, but that would be a less harmful way, because antibiotics can give you thrush, or, you know, we don't want drug resistance on antibiotics either.
Thank you, Dr. Pope. Barbara asks, could dark stool be a sign of stomach bleeding, as in watermelon stomach?
Yes, it could be. So we often ask, do you have, tarry stools that are like smelly and look like where you would be tarring the road? That to me is a sign that you could be bleeding, and that's often lower than the stomach. But dark stools could be bleeding if you have high motility transit going through. That could be bleeding dark stools from the upper bowel, but it could also be bleeding from the lower bowel. Frank red blood coming out is usually very low bowel, and red currant jelly is kind of low bowel as well. So yes, they could be, but dark stools can be dark from being iron, like taking iron. So not are all dark stools from bleeding, but I would ask your doctor, hey, should I have my stools tested for occult blood? And doctors know how to, like, there's a kit, you just give it to the person, or they get it and they check for blood in the bowels. But if you're on iron, you can have a false positive.
Okay, thank you. Frank asks, any promising treatments that may help reverse some of the fibrosis damage?
So you've had a lot of wonderful lectures already. So so far, it is highly unlikely that fibrosis in the GI tract will reverse. It's funny because someone asked, and about 20 people from all over the world answered. Someone said, "Hey, have you ever seen someone's GI involvement?" I don't mean improve because we can treat it, but reverse. And we had answers from all over the world. And so I read them. I just replied to the one person. A lot of people replied to all. And almost everyone said once in a blue moon, meaning once in their career, did they see someone who had terrible motility, that over time their motility came good again. But we've had times where the bowels are less symptomatic, other times more symptomatic. So they can cycle, but to fully reverse the fibrosis, not likely, which is it's a good question, but we can still treat symptoms somewhat for sure.
Thank you. What can caregivers do to assist when a choking episode occurs? These episodes happen just as often when not eating out of the blue. That's from Lori.
And that, Lori, that's very scary. It's scary for the person. It's scary for the caregivers. So first of all, if someone can make a noise, they still have their airway. So you don't have to do, we can't call it Heinrich anymore. You don't have to sort of push on their gut upwards, like they're right between your rib cage at the very top, below your breastbone. You don't have to do that unless if there's no noise, because you don't want to lodge it worse, but it's a terrible feeling. So watching the person, having water while they're eating, water, chewing your food well. A lot of people will end up saying, I don't do Rice Krispies or rice or steak. I do finely cut chicken, and sometimes roughage makes your bowels worse. Sometimes it improves them. So people kind of usually figure out the diet that can help them. But when it's choking and not sticking right here at behind your breastbone, that's the discoordinated swallowing all the way. If it's sticking right here all the time, where people say, I'm not choking, my food is stuck right behind my breastbone, those kind of symptoms, a dilatation from the GI doctor or the general surgeon might be very helpful. And if you get one dilatation and it helps, be on the lookout that later you might need another dilatation down the road, or serially, sequentially over time. And then you try to get dilatations before you're really stuck.
Okay, that's good advice. Thank you. Christine, I have rumbling in my stomach the next day. Don't eat past 6 p.m. and next morning stomach is making all kinds of noise.
Right, but that's probably normal hunger, and we're telling you not to eat till after 6 p.m. because we don't want you getting all this acid reflux and things like that. If your swallowing tube works well and you don't have interstitial lung disease, so very mild to no gastroesophageal reflux, you don't have discoordinated swallowing called dysphagia, then you can eat like a regular person, snacking a bit after supper and things. But I think your stomach's just rumbling because you're hungry, and that's like a normal thing.
Thank you for that. Let's see, next. Lisa, I had mammometry and 24-hour pH study done of the 7+ days of being off PPIs. The only day I did not have very bad reflux at night was the day I had the probe in. Will there be any useful information if I didn't have reflux?
Right. So first of all, you probably do have reflux. And, it's interesting because one of my great colleagues that sees a lot of our patients is he did extra training in like upper GI here for manometry. And so he occasionally does it on my patients, almost never, because we're going to treat the symptoms. It's kind of like if your mouth is really dry and I look and see that dry tongue like the picture, or I look and don't see a dry tongue. Either way, you're dry. So we treat the symptoms. So whether you had the worst ever or not so bad, we're still going to treat you according to symptoms, not according to your test. So sometimes manometry is done if they're wondering about, do you need other procedures done? What we're doing isn't working, things like that. So that's sometimes when they do it, it's like an aberrant response to treatment, what really is going on, but usually we don't do it. But yeah, I'm sorry that off your proton pump inhibitor, you were worse, but at least it tells you that you needed your proton pump inhibitor.
Thank you. Jillian, I've been on Losec for years. I heard that prolonged use can lead to loss of bone density. I started to take half cup of kefir every day and have been able to decrease my Losec by half. I make my own kefir, which has more than 50 different probiotics and yeast. Can you explain why this seems to help?
Right. So this is so kefir, to tell people, it's kind of like fancy different yogurt. So there's a lot of things that are yogurt like. So it's basically a natural bacterial culture happening. Usually, I think in all cases milk based. And so what's happening is I think we're getting the good guy bacteria that are helping to digest food and helping, like, we don't really know, but I wouldn't be surprised that normal bacteria in a bowel probably also help the natural functioning. So it doesn't make the stomach contract perfectly, but it's just the normal pH, which is, contractions can differ depending on the pH of the stomach as well. So that is like an excellent thing to tell others. I think it's great, and people can try it and see.
Thank you. I see there's another question, but I see Christine just responding from her question before, where she was talking about rumbling in her stomach and not eating past 6. And so I can see Christine, you responded there saying, I do have ILD and not hunger. So
Right. So fair enough. So then you don't want to eat after 6, but I guess when you wake up, just get on with things. But I mean, we all can have rumbling stomachs that if it's not painful, you're not really going to ignore the cue to eat your breakfast. But if it's not painful, that's good. And if it's not hunger, that's good too. But the rumbling, then I wouldn't worry about, and that's okay.
right. Okay. I think this might be our last question. We are trying to keep with time, so that's great. Kara asks, do you use hydroxychloroquine?
So, Kara, the answer is yes and no. So it depends. So I don't use hydroxychloroquine specifically for scleroderma skin. Like, I don't use it for skin. I'll use it for inflammatory arthritis. I'll use it if people have that Sjogren's overlap with big swollen glands or other Sjogren's features, such as inflammation of blood vessels on their legs, leukocytoclastic vasculitis. But Sjogren's, sometimes Plaquenil helps, but Plaquenil hydroxychloroquine can certainly help in some of our people with inflammatory arthritis and sometimes the puffy fingers.
And maybe if you still have time just for one more question.
Very quick question. So this is a good point. So this is Sylvia's had the bad watermelon stomach, and really bad, tons of transfusions, lots of lasering in the stomach and things like that. And now what they're trying to do is keep the hemoglobin, the low blood or anemia, up. Probably got IV iron along the way too. They're trying to keep it up with EPO. EPO is what we use for low blood. It's a hormone above your kidneys that makes, it's not a hormone like prednisone or testosterone, but it makes blood cells more. And so they're probably doing it because it's the only way to keep up the blood production, but there's still going to be blood loss, and they'll probably keep zapping that stomach ongoing.
Thank you. And thank you for the question, Sylvia. Thank you everyone for your questions. I think that is going to have to wrap things up for today. I want to thank you, Dr. Pope. I said it before, but I'm happy to share again how much we appreciate you here from the organizational perspective. You're always there when John, our executive director, or myself pick up the phone or send an email. So having you as an ally here from our perspective is so important. And we thank you for your time and for just always being there for us. We're so lucky to have you. Thank you.
Great. Thanks, everyone, and have a nice, happy Thanksgiving weekend.
You too.
Yeah. Bye-bye.
We'll talk to you soon.
You will. You will. Bye-bye.